Thank you. I'm so excited to be here. Um, so first, before we get started, I'd like to thank some very special colleagues and friends for their contributions and support over the years. So here's some of my colleagues, friends, students, and some former students. And also must give some appreciation to those who fund and support this work. All right. So before we get started, also, I want to just give a brief overview of our plans today. And this is kind of like a lightning round because 20 minutes is not a lot of time. So I hope to pack a lot in here. And we do have some time for some discussions after I get done. So if you have questions, let me know. So first of all, I want to talk about the impact of stroke-induced aphasia on health communication. And then we'll talk about the recent evidence supporting the use of AAC in aphasia rehabilitation. And then we'll close with what I'll call my offerings of how we can increase healthcare equity for people with aphasia. But please note, these are my opinions, but I hope they'll bring some discussion and perhaps spark ideas for research and change in clinical practice. So I'm going to start my timer here. All right. So when we think about the impact of aphasia, my colleagues and I in 2019 extrapolated the prevalence for aphasia in 10 of the most populous countries in the world using the NIDCD, which is the National Institute of Communication for Deafness and Other Communication Disorders, which is one of the primary funders for research in the United States for communication sciences and disorders. What they estimate the incidence of people with aphasia being 1 in 250 people in the US and the 2019 US Census Bureau population. And that yielded an estimated 18 million people having people with aphasia in those 10 countries. So in preparation for this talk, I repeated that review and added Bulgaria. And so as of today, the estimated prevalence for those same countries with Bulgaria is approaching 20 million people. And so even if we account for Bulgaria, that's a nearly increase 1 million people having aphasia. So what is striking is that it is more common, aphasia is more common than Parkinson's, cerebral palsy, and muscular dystrophy. However, most people have never heard of it, and they typically never will hear of it unless they personally experience it. And so it's really challenging when you're working in this field and working with patients because it's arguably the most devastating consequence of aphasia, but yet it remains under study and contributes to significant health inequities. So when we think about health equity of people with aphasia, stroke survivors with aphasia experience, compared to their stroke peers without aphasia, people with aphasia experience more adverse events, longer hospital stays, higher mortality rates, higher rates of depression, increased social isolation, and lower functional independence when they come through rehab. And people with aphasia from underrepresented minority groups experience significant residual impairment despite lengthier rehabilitation stays compared to white people with aphasia. And this is in the United States. So what does all this mean? This indicates that an urgent need to partner with people with aphasia, and especially those from underrepresented minority groups during the research process to make sure we develop interventions that are meaningful and helpful. So we're going to come back to this idea in a bit, but there's other challenges that people with aphasia face in addition, like additional health inequalities. So when we look at AAC in the early post-stroke rehabilitation process, physical deficits are quickly remedied with walkers and wheelchairs to make sure that they're safe, but also making sure that they have mobile independence, right? So as soon as there's a stroke, here comes a physical therapist with the wheelchair or a walker or a cane or whatever they need to be mobile but safe. In stark contrast, people with aphasia are not routinely provided the analogous supports, aka AAC. And so to help them facilitate person-to-person communications or patient-provider communication while their language is restricted. So this underscores a very significant concern regarding people with aphasia to participate in their healthcare decision-making during the early stages of recovery. Often a legal guardian, and again, I'm talking with my United States perspective, so I'm curious what, your perspectives are, because I know I'm talking to a very international audience. But often a legal guardian or a durable power of attorney is appointed for the healthcare management of the person with aphasia. And so, again, here's what the numbers look like over here. The American Speech Language and Hearing Association National Outcomes Measurement System, which is what practicing SLPs report that only an astounding 0.5% of people with aphasia receive AAC during their inpatient rehab stay. And so again, this is analogous to a 0.5% of stroke survivors receiving a wheelchair, walker, or cane if they need mobility support. Could you imagine? Could you imagine? So the numbers do not change that much when we look at acute care, skilled nursing, or outpatient rehabilitation, ranging from 0.5% to 1.5%. So shortly, we'll talk about why AAC may be implemented so frequently for people with post-stroke aphasia. But first, we'll explore communication partner training and its use in the medical setting. So communication partner training is really a gold standard. There's a lot of data behind it, and we know it works very well at revealing the person with aphasia's competency. And we know when used and used well, you can reveal their competency very well. We know that. There is no doubt there. But what we don't know is that what we know though is it's not been well studied in the medical setting. Okay, it's not been studied well there. It's usually more in the chronic stages and with volunteers and families in the chronic stages. Further, what we don't know is whether or not family members are viewed as appropriate candidates for communication partner training in the early stages of recovery. And this might pose a concern given that it's that period where the co-survivors are the most likely candidates to be designated as legal guardians during that time period and charged with making those critical healthcare decisions for their loved ones during that rehabilitation period. And so that's kind of the iffy period about communication partner training at this point. And so again, from my United States perspective, it's even more important is that the person's ability to consent to treatment and the right to decide upon a discharge destination, that's enshrined in law. And even more important to consider is that if the person did not speak English or if they were deaf, the process would stop immediately until the appropriate personnel were called in. The social worker would not decide that someone was without legal competence due to their inability to pass a competency evaluation in English or because they could not hear the questions. The process would stop until an interpreter was in the room. However, when assessing a person with aphasia, it's not uncommon to make these determinations without employing accommodations, despite the abundance of data indicating that most people cannot be supported or could be supported and have their competence revealed using communication partner supports. It just doesn't happen, right? So coming back to communication partner training in the medical setting, right? Because we know it works, but we are unclear about how it works, or if it works, or why it's not being used in the medical setting. So a CPT-only method leaves people with aphasia powerless when there are no trained communication partners or when the trained communication partners leave the room. So AAC would give that power back. So I'm not saying, it's like we need both, right? So it's like communication partner training is not happening, but we also aren't really doing AAC. So we need really high quality communication partner training, but we also need AAC. But if the trained partner leaves, we need AAC in there as well. But AAC gives that power back because if they have AAC, the AAC is not going to walk out of the room like a trained partner does. So that's my spiel on that. So in addition to that, I think we need to think about, remember, this is like lightning round, so I'm going to go quickly so we can have discussion if we need to. But in addition to that, I think we need to rethink how we do aphasia, AAC for aphasia, because there's also these deep-rooted beliefs that AAC and restorative approaches are mutually exclusive, meaning we can do AAC or we can restore. And that's a myth. We have to kind of rethink that. So let me just get all these up here. There we go. So implementing usual care to the exclusion of AAC leads to ineffective or absent patient-provider communication, which we just talked about, that whole thing we just talked about. Next, it leads people with aphasia to a sense of giving up when AAC is finally introduced. And I don't really have citations to give you here. This is from my personal experience. I did this when I was working clinically, and I've also had many people with aphasia share these experiences with me, that when there's this restore, 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 and then, okay, now we're going to give you AAC, it's this sense of giving up. So I'm happy to come back and talk about that. And then we also have data now, finally, to show that AAC actually can still help people get better. It doesn't stop the recovery, but it also actually leads to improvement. And I'm going to show you some of my data from my lab, but we actually have some data coming out from China. And so we have AAC is actually starting to take off, and we're actually getting recovery data in AAC from around the world now. And so there's data to show, just like we had data for years in kids showing it doesn't prevent development. We're getting that now in aphasia. So we can do both at the same time, just like PTs. They bring the wheelchair and they work on walking. We can bring the AAC and work on talking. So that's number one. Oh, sorry, I skipped over the second one. And then this idea that I've heard for a very long time, I get it in my grant feedback. I hear it around, that this idea that AAC only works for people who have like pretty good comprehension and are non-fluent. And the idea that you need to be able to understand a bit so you can kind of follow the instructions and understand the system. And if you have some verbal language, that you don't need the device because, well, you can talk. That leads to an entire subset of people not receiving AAC. Well, we now have evidence to show that that's not true, that both out of my lab and Wong and colleagues have shown people with fluent aphasia getting better using AAC. We've both shown people with global aphasia getting better using AAC. And so it's just that they get better differently. And I can go into that a bit more in the Q&A if you would like. And so they just get better differently. And I've shown that in discourse. And I think we just have to be a little bit more creative with the people who are more severe and more mild. And so there's a lot to unpack there. I just wanted to put that out there maybe as a teaser if you were interested. But also, there's a way to avoid looking at only aphasia types. And I wanted to share the AAC aphasia categories at communicators checklist. And I know that Kirsten Tonsing, and I hope I pronounced your name correctly, is going to talk about this in her talk. So I won't go into detail, but I provided you with a QR code to access it. But briefly, the AAC aphasia category communicators checklist offers clinicians a way to think about how a person is communicating and whether they are dependent or independent. And this is likely a much better way to structure treatment planning than aphasia types. So hopefully that's a teaser for the next talk. And that's all I'll say about it here. But I just wanted to kind of put that out there rather than hyper focusing on aphasia types for aphasia AAC treatment. Okay, so I'll move on and talk a little bit about my data in lightning format so I can get through to my offerings at the end. So in my lab, we developed the Promoting AAC-Induced Aphasia Recovery and Chronic Aphasia. And I see my typo, it should be induced with a D there. And so I want to go over there's multiple cue cards in the treatment. It's a 4-step intervention. And I'm just going to go over the primary one and the overarching goal, which was to instruct people with aphasia to speak the target as they point or use the AAC device. And it can be low tech too. It doesn't have to be a high tech. But the overarching goal is for people with aphasia to avoid learn non-use so that they are trying to say whatever it is they're pointing to. And if you work with kids, the closest approximation I have is that it's similar to the concept of aided language stimulation. So it's similar, right? And we can talk about that if there's any questions around that. So they first try to say it, and then they point to either the pictures or the words or the speak button, but they're always trying to say it. And the idea is they're activating the perilesional tissue that was damaged during the stroke. Okay, so let's breeze through some of the findings that we had. And in the studies that I'm going to talk about, there's 2 studies. One was the feasibility study up here, and one was the recent study that we're working on writing up. In the first one, we compared to usual care, and in the second one, we just had a larger number of patients that we were comparing them to themselves. And so as you can see, we saw an increase in the Western aphasia battery with some large, small to medium effect sizes here. And the first one was a 4-week protocol, and the second one was a 6-week protocol. So this is just reduction in aphasia severity following AAC treatment. And the effect was larger, a small effect compared to usual care in the first study. So that was a nice finding. And then in this slide here, we're looking at change in spoken language, and we did see a reduction in overall spoken output, but don't worry about that. I'll come back to it. We weren't concerned after we saw the next slide. So we did see an increase in the use of photographs to communicate, but only in the AAC group, not the usual care. Both groups use the text to communicate, but that wasn't surprising because usual care, we use text all the time with people with aphasia. And then in speak buttons, neither group used speak buttons, which we weren't surprised in usual care because they did not get AAC intervention. But even the AAC group, those people did not use the device to speak. And we were almost happy to see this because this was data to show that, look, even in a treatment we were expressly teaching them to use the device to speak, they still didn't use it after treatment because people with aphasia want to use natural modalities. So we were excited to see this data. Then in this is where we kind of redeemed ourselves. So even though they spoke less, they had more counted words compared to the usual care group, more correct words, fewer mazes, and better syntax, but only the AAC group. So that was exciting. And then we looked at communication effectiveness index, and this is only in the current study that we're writing up. And we saw huge effects on the change, and this was with no homeworks and the device staying with us. So that was pretty powerful. And in the feasibility study, we looked at language lateralization. So both groups were right lateralized, which is very common in stroke. So the right hemisphere kind of takes over. And so no one shifted left all the way because this was just a 4-week treatment, 3 times a week. So nothing intense, but they both shifted toward the left to be bilateral, like where both hemispheres were kind of working. And the very cool thing is the AAC group looked pretty similar. The red is post-treatment, looked very similar to the usual care group. So very fun that the AAC intervention helped the people perform similar post-treatment to the usual care group. And then we looked at activation in some visual networks and the fusiform gyrus, which is known for writing and reading and object and face recognition. We saw increased activation intensity in those regions as well. So we're looking at some unique possible supports following AAC intervention. So I know I'm going fast, but there's Q&A time if we need it. So now that we've discussed some of the data from my lab supporting how AAC can be used as a dual purpose tool, I want to review one final way that I think, again, these are Dietz's opinions, that we maybe need to rethink AAC in language recovery. So AAC is often implemented in a manner that allows people with aphasia to talk about basic wants and needs, like requesting food and going to the bathroom. These can often be met through caregiving routines. I'd like us to revisit for a minute Janice Light's purposes of communications. And those needs and wants are definitely, I'll bring up the internal dialogue. Needs and wants are definitely a quadrant, but there are three other important ones. And when you're in the hospital, information transfer is very, very important when we talk about those health equity, patient provider communication. We're not getting in this quadrant nearly enough. And then when I was working with patients, one of the things that they loved to be able to say and communicate was, I love you, I miss you, how are the grandkids, all those social closeness things. And if you can get into social etiquette and just have some of the normal back and forth banters that we all do. So I think we're ignoring these way too much with our adults with aphasia. So I would be remiss if I didn't bring this up and bring this to our attention. So as I wrap, I want to share with you my offering to increase healthcare equity and normalcy for people with aphasia. Oh, look, and you see my reminder to write my script for this. And I did do that, so we'll end almost on time. So I offer that we should understand that AAC and usual care are not mutually exclusive, and that perhaps we think like a physical therapist and start early. That we step beyond wants and needs and use Light's communication purposes to develop treatment goals, to help remind us of the areas we need to consider. And that we implement AAC as a dual purpose tool, not just to compensate, but to help restore and recover language at the same time. Again, like physical therapists with that wheelchair, and avoid learn non-use. And that we offer AAC to all people with aphasia who have a communication gap while considering Garrett and Lasker's AAC categories of communicators. And we can do this probably more efficiently and effectively if we collaborate with key partners to understand their needs during early rehab with stroke survivors, co-survivors, and clinicians. And if you're a researcher, this would include other speech language pathologists, physical and occupational therapists, social workers, nurses, physicians, and anybody else that I left off. And so that's my offering, and I'm happy to take any questions.
Thank you. Thank you very much for this very interesting talk. So, let me see. There are no questions in the Q&A, so please, any questions?
There is a question or a comment in the chat, but it's in Ukrainian, so
let's translate
I need time to translate
Okay.
it.
So I have a naive question. I'm very happy about you agreeing to talk because we are in contact with a hospital in Bulgaria where they treat aphasia. It's a medical hospital and department, so they were completely ignorant about the AAC. So we try to motivate them, and but I would like to ask why in the first place occurred this opposition of AAC and restoration? It is very similar kind of this problem that we discussed in the previous talk, that people think that children wouldn't develop natural speech if they use AAC. So why this in the medical settings where people kind of would accept maybe more easily new ideas, this opposition happened to be?
Well, my career began in the schools, and so I remember, 20 plus years ago having the same battle with parents and children. And it's the same sort of fear for the same reasons I kind of discussed, is that, they worry that it's going to interfere with speech. And I think a lot of it too, I think some of it too is perhaps training in our programs and confidence with how to approach it. That maybe some clinicians, this is speculation, right? That some clinicians maybe just don't have some comfort in how to approach AAC approaches with it. But also, and just speaking from my experience, I was just so adamant that I was going to get this person's language back. And then I was like, then I was going to bring AAC in after they had plateaued. And that's just kind of the approach that, we're going to restore, and then bring AAC in. But it's just kind of, my analogy is like PTs don't make people lay in bed until they can walk, right? So why do we make people wait until they can talk before they can communicate? And so that's just kind of like my campaign is, why do we do this? Why do we do this? And so I think my approach is, if we can bring in AAC at the same time that we're restoring and help them see it's just a tool, then they won't be afraid of it. Because, and again, this is my opinion because I don't have data for this, but I think if we brought it in then they wouldn't be afraid of it. Because I think if it's brought in after you've worked restoring, and then you bring it in, then they're going to say, oh, you're giving up on me. And this is what you do when you give up. Then they think, oh, I'm not going to get my speech back. I don't know if that makes sense.
Thank you.
I have translated the comment in Ukrainian.
Okay.
So it reads, the topic of aphasia is relevant now for Ukraine more than ever. Many servicemen need help. I think, unfortunately, this is like that. And there is also another question in the chat. Shall I read it, Maurice?
Sure. Yeah.
Yes, go ahead.
The question, how can we break the social barrier with aphasic patients using AAC? They don't want to use their device in social situations.
Yes. What if it was more like an iPad mini or something that's more similar to what we use in every day? And I say we with my United States lens. So in my last study, we used iPad minis, which is about as small as I think stroke patients can use, but it's pretty similar. And my last grant paid for them, and then my patients got to keep them. And they didn't seem to mind using those because it's pretty similar to what people are using these days in the West. So I don't know what your comments or perspectives are on that.
It's a general recommendation also for children to make their devices similar to what everybody else is using, or even fancier. So
Yes. Yeah.
There is maybe a final question. Are there any studies that would show that there is no contradiction between AAC and speech recovery?
Yes, there's several studies. And if people want to email me, I can get those to them.
Okay, thank you.
Thank you very much. for
Mhm.
joining us.
Mhm.
And we continue with the next speaker.